Tolerance and effect of sodium thiosulfate in calcific tendinitis of the rotator cuff. Yo, what's up? It's someone that's an one, and welcome back to today's report. Today's report is coming from, sorry if I get this wrong, these are some names. C. Darrieurtort-Laffite, A. Bertrand-Vasseur, T. Garraud, L. Planche, and B. Goff, where they have a case report of using sodium thiosulfate. And here's the full report details. Alright, here's another unique report for the channel, a new substance presentation on top of that. Today we're bringing out the substance sodium thiosulfate, which was brought up in a report we covered with cyanide, as it's one of the main active ingredients in the antidote. Through time we covered the other things in there, like amyl nitrate and sodium thiopental. But here's a report that highlights the usage of sodium thiosulfate. I was kind of holding off on this one because this isn't a standard ingestion that we cover, or even a procedure we ever covered. That's because this has to do with the shoulder region, specifically in this case, calcium deposits and tendons, and it's more so on the outside. But it is still a human ingestion nonetheless. We get some good insights and see how it maybe can be applied for something by itself. So I'm sure you'll enjoy this one. Without further ado, let's dive right into this. Abstract. Background. Calcific tendinitis of the rotator cuff is one of the most common causes of shoulder pain. Ultrasound-guided percutaneous lavage of calcific tendinopathy is performed when conservative treatments have failed. Sodium thiosulfate, STS, has recently been used with success in the treatment of tumoral calcinosis. The goal of this phase 2 study was to assess the tolerance and the feasibility of STS lavage of calcific tendinopathy. Methods. We included patients with type hard calcifications. Patients were treated with puncture and lavage, followed by ingestion of STS in the calcification. VAS pain at rest and during activities, ultrasound, and X-ray were evaluated at 1 week and 1 and 3 months. Results. 17 patients were included. Baseline VAS at rest and during daily activities was a mean 40.2 plus minus 25.9 and 65.5 plus minus 21.6, respectively. All patients underwent the entire procedure with no adverse event. Calcium backflow could be attained in 15 patients, 88.2%. 5 patients, 30%, had more than 50% decrease of their calcific deposit size at 1 month, and 8, 47% patients, at 3 months. VAS pain during activities and at rest decreased significantly at 3 months. Efficacy will be demonstrated if 60% of the patients had more than 50% decreased size of their calcification. Conclusion. Overall, STS was well tolerated with no side effect occurring during the procedure and the follow-up. However, no significant effect on the calcium disappearance could be demonstrated compared with what is expected without STS. New studies using larger volume and repeated ingestions of STS are now needed. Introduction. Calcific tendinitis of the rotator cuff is one of the most common causes of shoulder conditions, affecting about 10 to 42% of patients referred for a painful shoulder. It is characterized by calcium phosphate crystal deposition in the rotator cuff. Its pathogenesis and etiology remains unclear, and the mechanisms leading to this pathological mineralization are still largely unknown. This disorder can lead to a chronic pain during daily or professional activities, and to a restriction of range of motion. During the disease, spontaneous resorption can occur with migration of apatite crystals into the subacromial bursa, causing severe pain and restriction of movement. Factors associated with the development of symptoms are still unclear, although the size and presence of a bursitis on imaging have been shown to be associated with pain. Ultrasound-guided percutaneous lavage UGPL Our barbotage, or irrigation of calcific tendinopathy is indicated when conservative treatments, physiotherapy, nonsteroidal anti-inflammatory drugs have failed. As it is a more complex procedure than a simple US guided injection, it is performed in some rheumatologic and radiologic departments specialized in interventional rheumatology. At this stage, extracorporeal shockwave therapy, ESWT, or subacromial corticosteroid injection can also be discussed. However, a recent number of meta-analyses have shown that UGPL could be the treatment of choice compared with the other non-surgical options such as ESWT or SAI. Arthroscopic removal of the calcium deposit is considered as a second-line therapy after failure of UGPL or EWST. Efficacy of UGPL depends on the type of calcification. Calcific deposits can be differentiated in hard calcifications, usually dense on X-ray with an acoustic shadow on US, and soft calcifications with more heterogeneous or faint contours without acoustic shadowing. Yu et al. Observed failure only in patients presenting with a dense and homogeneous calcification type A according to the Mole classification. Krasny et al. Also showed that the outcome after needling and/or ESWT was worse in the case of dense calcifications, with only 30% success compared with 61% in patients with soft calcification. These failures are most of the time explained by the persistence of a calcific deposit. In line with this, Del Castillo et al. Found a positive correlation between the decrease of size of the calcification and the pain score over time. As the calcification became harder, the pain became less intense. Importantly, Aina et al., who first described the US guided needle lavage technique, confirmed the importance of calcium extraction to attain a clinical improvement. Patients in whom calcium deposits in the rotator cuff were successfully aspirated had a clinically significant improvement in the pain and disability compared with the subgroup of patients in whom no calcium was aspirated from the rotator cuff. Serum saline solution is currently used to perform lavage of the calcium deposit after local anesthesia. Several approaches are currently used to facilitate the extraction of the calcification. It has been shown that lavage with warm saline, heated at 42 degrees Celsius, reduced the procedure duration and improved calcification dissolution. Another randomized controlled study recently reported that lavage with a 2-needle approach also shortened the procedure and hard calcification. However, none of these studies showed an impact on the rate of calcification elimination. Other strategies are therefore needed to treat hard calcification of the rotator cuff. Sodium thiosulfate, STS, is primarily used to prevent and treat cyanide poisoning. Intravenous STS is also used off-label to treat calciphylaxis, leading to a significant decrease of soft tissue and vascular calcifications. However, its systemic use may be limited by side effects or adverse effects such as hypotension, muscle cramps, nausea, vomiting, gastrointestinal upset, agitation, blurred vision, hallucinations, anion gap metabolic acidosis, and sodium overload. Therefore, it's required to monitor closely during and after the perfusion. Thus, alternative local approaches have been developed. Recent reports have shown the interest of topical STS in the treatment of calciphylaxis, tumoral calcinosis associated with connective tissue disease, pseudohypoparathyroidism, or hyperphosphatemic familial tumoral calcinosis. For instance, a daily application of topical STS on the calcific lesions of patients with hyperphosphatemic familial tumoral calcinosis led to their decrease after 5 months of treatment. Has also showed an anti-inflammatory effect in patients with calcinosis cutis secondary to connective tissue disease and angiodermatitis. Because deeper calcific deposits are likely to be reached by topical therapeutic agents, some authors perform intralesional STS injections in patients with localized cutaneous calciphylaxis. They observed a complete healing of ulcers and remission of disease. The only side effects observed with intralesional injection are patients complaining from mild localized discomfort during injections. No adverse event has been reported during the follow-up of the patients. Despite these promising results, the exact mechanisms by which STS is able to dissolve ectopic calcifications remain still unclear. These preliminary results prompted us to study the interests of STS in the treatment of calcific tendinitis. As dense calcifications are associated with higher risk of failure of UGPL, we selected these patients to perform a lavage followed by an intralesional injection of STS. The objective of our study was to evaluate the tolerance and the feasibility of sodium thiosulfate lavage in the treatment of calcific tendinitis. We also assessed its effects on clinical symptoms and radiographic evolution of the calcific deposit. We hypothesized that sodium thiosulfates will be well tolerated and fasten the elimination of the calcific deposit in patients with dense calcifications. Methods. The current study was a prospective, monocentric, phase 2, single-group, open-label study conducted at the Nantes University Hospital, France, September 2, 2015. The protocol was approved by institutional medical and ethics review boards, and all participating patients signed informed consent forms. Study population. We included patients referred to a rheumatology department for the treatment of a calcific tendinitis. Inclusion criteria were the following: age over 18 years old, pain for more than 3 months, worsening of symptoms with activities above the shoulder, minimum one of the 3 following impingement positive clinical test, calcification greater than 5 mm in size on the standard anterior-posterior AP radiographs. We included only type A calcification according to the Mole classification. We excluded patients on the following criteria: allergy to sodium metabisulfite, asthma, chronic renal disease, creatinine clearance less than 30 milliliters per minute, type B or C calcification according to the Mole classification, other shoulder disease, glenohumeral or acromioclavicular osteoarthritis, rotator cuff tear, rheumatoid arthritis, previous pubescutaneous irrigation of the same calcification. Baseline clinical, radiological, and ultrasonographic evaluation. We recorded the main demographic characteristics: medical history, occupation, dominant hand, presence of nocturnal pain, and day off work because of the shoulder pain. VAS pain at rest and during activities, shoulder pain of motion, DASH score, and EQ5D quality of life VAS score was also recorded. X-ray of the affected shoulder was performed. Antero-posterior view in neutral and internal and external rotation and lateral scapular view. Calcification types were classified according to Mole et al. A. Dense, well-defined, and circumscribed. B. Dense, well-defined, and segmented. C. Transparent and non-homogeneous. Surface of the calcification was measured on the view where the calcification appears the largest. The same view was used for all measurements during the follow-up. Density of the deposit was evaluated on the same view. All the measurements were made by an experienced musculoskeletal radiologist blinded from clinical status, ABV. We used the Picture Archiving and Communication System, PACS, with automated distance, surface, and density calculation. Intervention. All patients underwent a baseline clinical, X-ray, and US evaluation by rheumatologists with 11 years, BLG, and 5 years CDL experience in US and US guided interventions. Patients were treated with a US guided single needle technique. After sterile preparation, local anesthesia was performed under US guidance. A total of 10 milliliters of lidocaine, 1%, was injected in the subcutaneous tissues, the subacromial bursa, and over the surface of the calcific deposit. A 21-gram pediatric spinal needle was used for the procedure to prevent needle clogging by calcific debris. Indeed, introduction of the needle with the stylet prevents the needle to be clogged. Once the needle tip was inside the calcification, the stylet was removed and the lavage could start. When backflow of the calcific material could be identified in the syringe, lavage of the deposit was performed using sodium thiosulfate 25%. A volume of 1 milliliter of sodium thiosulfate was prepared in a syringe, and successive propulsion and aspiration was performed. The procedure was repeated until the backflow becomes clear. At the end of the procedure, 1 milliliter, 250 milligrams of thiosulfate was injected inside the calcific deposit. Finally, 1.5 milliliters of Cortivazol, Altum, Sanofi Aventis, was injected in the SAB. X-ray of the shoulder was performed just after the procedure. Patients were treated with Diclofenac, 75 milligrams LP twice a day, and Paracetamol, 1,000 milligrams 4 times a day, for 48 hours, then only if needed. Routine use of the shoulder was allowed without restrictions, and all patients had 1 week off work. Results: baseline clinical characteristics. A total of 17 patients were included. Mean age was 50 plus minus 11 years. There were 9 female, 52.9%. 11, 64.7%, had previous SAV steroid injections, but more than 1 month before inclusion in the study. Height, 47.1%, had a physical occupation with repetitive movements of the upper arm. 2 patients, 14.3%, were off work because of their shoulder pain. Clinical tests for subacromial impingement were positive in 17, 100%, 16, 94%, and 14, 82.4%, for the Yoakum, Hawkins, and Near test, respectively. The other baseline characteristics are summarized in Table 1. Procedure. All patients underwent the entire procedure. Calcium backflow could be attained in 15 patients, 88.2%, allowing lavage with sodium thiosulfate. A small amount of calcium could be aspirated in 8 cases, 53.3%, whereas a large quantity could be extracted in 7 cases, 47.7%. Ease of calcium dissolution was not changed with sodium thiosulfate lavage compared with our experience with saline solution. At the end of the procedure, all patients received an intracalcic injection of 1 milliliters of sodium thiosulfate, followed by 1.5 milliliters of Cortivazol injection in the SAB. 1 patient had a mild and transient vasovagal reaction. No adverse effect, allergy, pain was recorded during the procedure or the follow-up. There were no cases of frozen shoulder. Discussion. In this Case 2 study, we demonstrated that lavage with STS was feasible and well tolerated in the short as in the long term. However, we did not observe a significant effect of STS or on the ease of calcific deposit dissolution, nor on the short and mid-term radiographic evolution of the calcification. We found that 29.4% of patients had more than 50% decrease of the calcification size at 1 month. This result is comparable to the one we previously observed with a lavage using a saline solution. Finally, our main objective was to evaluate the tolerance of local ingestions of STS in the rotator cuff tendons. Intravenous use of this molecule in patients with calciphylaxis was associated with secondary effects such as self-limiting nausea, vomiting, headache, blood pressure variation, and asthma. We did not observe any of these systemic effects during or after the lavage/injection. Moreover, follow-up of the US imaging did not reveal any local change, such as an increased rate of bursitis or Doppler signaling that remained stable during time. Our results are in accordance with other studies reporting a good tolerance of topical application or subcutaneous injection of thiosulfate. The short half-life of the molecule, the local delivery, and the low dose we used may explain this excellent tolerance of local sodium thiosulfate treatment. Our study has several limitations. First, as mentioned earlier, we performed only 1 lavage with STS per patient. It is not excluded that multiple injections will be needed to observe a significant change in the size of the calcification. Second, this was a feasibility phase 2 study with no control group. Our main hypothesis was, based on our experience and on the rate of the radiographic disappearance of the calcific deposit reported in the literature. A controlled study comparing STS and serum will be needed to definitely conclude on the absence of effective STS. Third, we used a single needle technique with a 21G needle as performed routinely in our department and described by Aina et al. It has been suggested that the use of the 2-needle procedure might be more suitable for dense calcifications. However, a recent study has shown that this type of procedure did not change the ease of calcium dissolution or the clinical evolution, despite a shorter duration of the procedure in case of dense calcification. Conclusion. Overall, our study is the first to evaluate the tolerance and efficiency of sodium thiosulfate for the treatment of the calcifications of the rotator cuff. This treatment was well tolerated with no side effect occurring during the procedure and the follow-up. We could not demonstrate a significant effect of the STS lavage and injection in patients with dense calcification. New studies using larger volume and repeated injections of STS will be needed to definitely conclude on the interest of this molecule in the treatment of calcific tendinitis.